Hello everybody. Today we are going to discuss the case of thrombocytopenia and overall approach how to deal with it. So we have this 48-year-old male patient who was a known case of type 2 diabetes mellitus. He came with the chief complaint of cough since 10th of January. Initially he consulted only on the OPD basis and received the antibiotic. Cough got improved but he started developing rash over the lower lip. So on arrival in ICU, temperature was 98, pulse rate was 83, blood pressure was 140 by 90, and respiratory rate was 90. Rashes present all over lower limb and patches were there. So on systemic examination, CVS S1, S2 normal, RS air entry was equal on the both side. Per abdomen soft, non-tender, and CNS patient was conscious. So this was the lab report of the patient. As we can see here, his platelet counts were critically low, that is only 4,000. So in view of low platelet count, we have transfused 6 point of STP, and we have started him on the other supportive management like PAN and Optineuron. So next day his platelet count came 16,000. To evaluate cause for thrombocytopenia, we have planned for bone marrow biopsy and we have started him on the steroids. So bone marrow biopsy provisionally was suggestive of ITP. Next day his platelet counts were 69,000 and patient was discharged. So we'll discuss the case of thrombocytopenia in ICU. Thrombocytopenia is one of the most common hematological abnormalities encountered in the ICU with an incidence ranging from 13% to 65%. So thrombocytopenia is defined as absolute platelet count of less than 1,50,000 or decremental greater than 50% from the baseline. So what is the mechanism behind? So platelets are versatile cell with a wide range of function, like taking part in several diseases affecting different organs and organ system. Normally, complex interplay between bone marrow, liver, and reticuloendothelial system maintain the constant platelet count in the individual. In critically ill patient, mechanisms contributing to thrombocytopenia are poorly understood. The reason for thrombocytopenia in ICU are numerous and often multiple mechanisms which act simultaneously, but can in general be divided into central cause, like there will be impaired production or dysfunction of bone marrow, and peripheral cause like platelet destruction, increased sequestration, then pharmaceutically induced thrombocytopenia and hemorrhage. So common mechanisms are decreased production, increased sequestration of platelet, increased destruction, then enhanced consumption and pseudothrombocytopenia. Now the mechanism of thrombocytopenia with the different examples. Like increased consumption will occur in conditions like DIC, TTP, HELP, and decreased production will occur in this chemotherapy, radiotherapy, sepsis, alcohol intoxication, and it could be drug induced. Then increased sequestration will occur in conditions like hyperspenism, CHF, and hypothermia. Increased destruction will occur in non-immune conditions like TTP, DIC, sepsis, drugs, mechanical devices, and immune thrombocytopenia like HIT, ITP, drugs, and sepsis. Then it also occurred in the hemodilutions like uh, hem- because of it also occurred because of hemodilution, like because of the infusion of fluids, transfusion of RBC concentrate and plasma, and sometimes it could be pseudothrombocytopenia because of because it could be EDTA induced or glycoprotein 2b3A inhibitor induced. What is pseudothrombocytopenia? So this is the lab artifact usually caused by in vitro platelet agglutination in EDTA anticoagulant blood. So the platelet clumping occur due to naturally occurring autoantibodies against an epitope on glycoprotein 2b3A. So the platelet counts are falsely low because the blood analyzer does not count the platelet clump, and platelet count in citrate anticoagulated blood are usually normal but not always. So pseudothrombocytopenia may also occur from in vitro adherence of platelet to leukocyte, known as satellitism, which can be identified by examination of peripheral blood smear. It has been consistently observed in 1 in 1,000 individuals and is not related to the presence and absence of the disease. Pseudothrombocytopenia has no major clinical implications except that most of the patients end up with the unnecessary transfusion. Now, the decreased production and increased sequestration. The extent to which these mechanisms contribute to thrombocytopenia in ICU is not and are unlikely to be dominant factors unless the patient has pre-existing problem, with few exceptions. For example, acute alcohol intoxication is also known as thrombocytopenia through decreased production. In patients with sickle cell disease, where splenic sequestration crisis is known to cause thrombocytopenia. In disease states that with high pro-inflammatory activity like sepsis, erythropoiesis is blunted, but thrombopoiesis is stimulated and hence a rare cause. Now, the conditions associated with increased destruction, consumption, or both. Destruction and consumption of platelet due to both immune and non-immune mediated mechanism explains the most common cause of thrombocytopenia in ICU. And the probable mechanism include thrombin-mediated platelet activation, development of antibodies, hemophagocytosis, complement activation, histone-mediated platelet aggregation, and Adams ST313 depletion. The classical clinical scenario are patient with the trauma and sepsis. Now, what happens in sepsis? So, sepsis, multiple mechanisms have proposed to explain the thrombocytopenia of sepsis, and the relative contribution of each potential mechanism may vary among patients in the same patient over the time. So, enhanced platelet consumption result from ongoing thrombin generation and increased adhesion of the platelet to the endothelial cell. Excess endothelial activation characteristic of the sepsis is associated with the release of large amount of 1 Milgram factor multimer and reciprocally decreased amount of multimer cleaving protease such as Adams 30. The exaggerated endothelial activation allows the large number of the platelet to be attached to the vascular endothelial cell, leading to thrombocytopenia. There is also increased evidence for platelet interaction with the white cell through formation of platelet neutrophil aggregate and platelet monocyte complexes in sepsis and other inflammatory conditions. A newly identified reason for thrombocytopenia and critical illness is the effect of extracellular histone. Animal studies have shown that rapid histone infusion causes the rapid and profound thrombocytopenia through platelet aggregation. This aggregatory effect is mediated by activation of integrins and cross-linking of platelet and fibrinogen. The study also shows that high histone level during ICU stay strongly predict the development of moderate to severe thrombocytopenia. Now, the common causes in ICU are sepsis, trauma, TTP, HOS, DIC, drug-induced, heparin-induced, massive transfusion, vascular devices, and post-surgery. So we'll see this one by one causes. Sepsis. Sepsis accounts for 50% of incidence of thrombocytopenia in critically ill, and it is often multifactorial. So thrombocytopenia is known to be independently modify the host immune response to sepsis. So hemophagocytosis is the frequent cause of unexplained thrombocytopenia in patients with severe sepsis syndrome. Now, the next is trauma. Trauma-induced coagulopathy together with the hemodilution due to massive transfusion is common cause, along with the consumption, hyperfibrinolysis, and systemic inflammation. Now, TTP and HOS. TTP is described as the pentad of fever, thrombocytopenia, then this microangiopathic hemolytic anemia, renal dysfunction, neurological impairment, and often some of these features are not present and often may be confused with HOS, which is commonly characterized by the triad of thrombocytopenia, renal dysfunction, and microangiopathic hemolytic anemia. So these clinical similarities of DIC, TTP, HOS are major concern because they pose the risk of misdiagnosis. As clinicians are more likely to consider the diagnosis of DIC rather than rare TTP or HOS, thus delaying the potentially life-saving treatment. Now, hemolytic anemia, negative Coombs test, elevated LDH level, organ dysfunction with thrombocytopenia are common to DIC, TTP, and HOS. But the most important distinguishing factor between the DIC, TTP, and HOS is coagulation factor, because as the patient with the DIC have altered coagulation. Now, what is DIC? So, DIC is relatively uncommon, developing in 9% to 19% of ICU patients, usually as a result of sepsis. And DIC may not be viewed as a coagulation disorder, but as a delayed symptom of emerging systemic vascular inflammatory disease and endothelial dysfunction. Now, the next is drug-induced thrombocytopenia. Thrombocytopenia caused by drug-dependent antibodies occurs suddenly and is typically severe and is often misdiagnosed, therefore commonly recurs. Now, drug-induced non-immune thrombocytopenia is frequent cause, and with exception of HIT, the immune-mediated thrombocytopenia is less frequent. So, lab tests for detection of drug-induced antiplatelet antibodies are helpful to support the diagnosis. However, these tests are performed only in specialized labs and are usually not available to guide acute management. The clinical relevance of lab testing for drug-induced antibodies is two. First, it allows objective confirmation of adverse drug effect. Second, it is important for individual patient so as to avoid future exposure to specific drug. Drug causing thrombocytopenia and associated with drug dependent antibodies like vancomycin, trimethoprim sulfamethoxazole, piperacillin, rifampicin, and oxaliplatin. Heparin-induced thrombocytopenia. It is one of the most important adverse drug event encountered by the physician. It is a life-threatening immune-mediated prothrombotic state, most commonly encountered with unfractionated heparin and to a lesser extent with low molecular weight heparin, associated with platelet-activating anti-platelet factor 4 and heparin antibodies. Incidence of HIT varies among these studies because of the wide range of underlying comorbidities and co-administration of many drugs simultaneously and critically ill. Timing of onset, moderate nature of thrombocytopenia, and the common concurrence of thrombosis are a very important factor to differentiate HIT from the other explanations for thrombocytopenia in ICU patients. Several clinical scoring system has been proposed for diagnosis of HIT, and the most widely employed is 4T score. Similarly, various lab investigations are also available for diagnosis of HIT, but the gold standard for diagnosis at the point of time is serotonin releases. Now, significance of thrombocytopenia developing during ICU admission. Now, the multiple studies have shown that development of thrombocytopenia during ICU admission is associated with increased length of stay, morbidity, and mortality. This association has been noted in both medical and surgical patients in pediatric adult patients and is particularly apparent as a prognostic indicator in sepsis. Now, the patients who developed thrombocytopenia had more episodes of major bleeding compared to those who did not develop thrombocytopenia and also received more blood product transfusion. Thrombocytopenia has also been associated with ARDS. Several experimental and clinical observations have demonstrated that platelets are integral to barrier function of alveolar capillary endothelium. So thrombocytopenia can lead to disruption of this barrier integrity and lead to pulmonary edema, which is a characteristic of ARDS. Now, the animal data shows that during mechanical ventilation, platelet release chemotactic protein, which promote leukocyte recruitment and pro-inflammatory mediators, which is a characteristic of ARDS. Of late, the correlation between low platelet at admission and host response has been studied in septic patients, which has shown positive correlation of low platelet count with increased cytokine, endothelial cell activation, and impaired vascular integrity. Impaired leukocyte adhesions and increased complement signaling, suggesting impaired host response. Persistently low platelet count and duration of thrombocytopenia were crucial for prognosis. Now, approach to thrombocytopenia in ICU. So first, we should collect detailed history. We should carefully perform the physical examination. Systematic and extensive investigations are required to establish the cause of thrombocytopenia in ICU. To understand the likely cause of patient's thrombocytopenia, it is essential to have full picture prior to medical history, comorbidities, and medication. Always obtain previous CBC report to look if the patient has unrecognized pre-existing disorder, for example, CLD and IT. The illness has led to ICU admission should clearly understood. For example, patient admitted to with UTI may become progressively worse and may land up with septic shock, multi-organ disorder syndrome, which itself is the known to cause thrombocytopenia or HSP secondary to sepsis. So with reference to the course of illness, always look at CBC obtained during early course of the disease and always rule out lab artifacts. Now also look at the timing of the platelet drop. For example, if it is acute drop of more than 50% in less than 48 hours after any intervention or procedure goes in the favor of thrombocytopenia secondary to that intervention. For example, if thrombocytopenia developing after giving drug to cause low platelet count like vancomycin, a platelet or patient developing low count after insertion of vascular devices like IBP and TPA. Similarly, heparin-induced thrombocytopenia is known to occur after 5 days of exposure to unfractionated wet heparin, unless the patient has been previously exposed to unfractionated wet. Look for the evidence of hemolysis or abnormalities in coagulation profile, where diagnosis narrows down to DIC, microangiopathic hemolytic anemia, and TTP. Any associated thrombosis narrows down the diagnosis. Now, the HIT is classical example, and DIC associated with malignancy is another presentation. If thrombocytopenia is a part of pancytopenia, bone marrow examination is required to rule out malignancy. Every patient with thrombocytopenia in ICU need to be investigated unless the platelet count is less than 1,000, 1 lakh, 30% drop in platelet count, rapid decline in platelet count, failure to increase after 5 to 7 days of appropriate therapy, then a decline in platelet count after initial. Now, how to manage this thrombocytopenia? Thrombocytopenia is usually consequence of underlying illness, and specific management of underlying disease should result in improvement of platelet count, and hence importance should be given to appropriately treating the condition. Now, the spontaneous bleeding is the biggest fear the clinician face while treating patient with thrombocytopenia. Life-threatening bleeding is rare with a platelet count of more than 20,000 and rarely requires transfusion unless the patient is bleeding or is planned for invasive procedure or surgery. Randomized trial of transfusion strategies to treat or prevent bleeding in the thrombocytopenic ICU patient have not been conducted, and conservative approach seems warranted. Challenge faced by intensivists is to prevent unnecessary transfusion and at the same time keeping in the view the risk of massive bleeding if not transfused. The most commonly accepted platelet count threshold for transfusion are the level of 10,000 for those without and 20,000 for those with the additional risk factor for bleeding, such as concomitant coagulopathy, like conditions like DIC, or severe hepatic or renal dysfunction. If platelet dysfunction is possibility, the higher threshold of 50,000 should be considered. If neurological complications like intracranial bleed may have occurred, a threshold of 1 lakh has been suggested. In those patients who are not bleeding, the platelet transfusion may be required if there is a need for surgical and radiological intervention. Thresholds for platelet count have been set for many procedures, which are often undertaken in ICU with very poor evidence base. Now, therapeutic platelet transfusion. In the context of massive transfusion, treatment of bleeding with 1:1:1 or 1:2:1 ratio of platelet cells plasma platelet It's supported by clinical studies and widely recommended in clinical guideline to prevent severe thrombocytopenia or hemodilution of coagulation factor. The optimal ratio of platelet concentrate in these settings remain unknown. Caring for patient requiring massive transfusion is complex. Comprehensive transfusion protocol can help achieve transfusion goal and improve outcomes. In general medical or surgical ICU patient with severe bleeding or in the absence of informative clinical trial, current guidelines recommended that platelet transfusion be considered if platelet count is 50,000 or if significant platelet dysfunction is suspected or confirmed. Platelet dysfunction is relatively common in the ICU or may be aggravated by factors including uremia, liver failure, antiplatelet agent, and extracorporeal circuit. The extent to which platelet transfusion can overcome this effect is unclear. Now comes prophylactic platelet transfusion. So most platelet unit in the ICU are transferred to prevent clinical bleeding. Clinical trials to guide best practices are needed and considerable practice variability exists. The extrapolating from randomized trials evaluating prophylactic platelet transfusion in a hospitalized adult patient with chemotherapy-induced hypoproliferative thrombocytopenia, the American Association of Blood Bank and the Society for Critical Care Medicine 2016 Surviving Sepsis Guideline recommended prophylactic platelet transfusion below threshold of 10,000. This extrapolation, however, may not be valid, and in patients admitted to the medical or surgical ICU, thrombocytopenia is frequently multifactorial and may be accompanied by acquired platelet dysfunction, but also increased platelet turnover. Furthermore, the post-transfusion platelet increment and the durability of platelet increase are known to be attenuated in ICU patients. In observational studies, the median increase in platelet count per platelet transfusion was 15,000. Now, what about peri-procedural platelet transfusion? The platelet transfusion is recommended to minimize bleeding during placement of elective central venous catheter if platelet count is 20,000. Data to support this recommendation came from observational studies, of which subset of patients are admitted to the ICU. So the two large observational studies, only patients with the pre-procedural platelet count of 20,000 were 20,000 or 25,000 were at the risk of bleeding. And central venous catheter should ideally be placed under ultrasound guidance by expert operator to reduce the risk of bleeding. With the use of bedside ultrasound and clear vascular windows, the incremental benefit of platelet transfusion is uncertain. In the absence of informative trials, practice variability exists. The recommended platelet threshold for lumbar puncture surgical procedure are summarized in the following way. Like in case of severe bleeding, threshold should be 50,000. If for prophylaxis in adult, it should be 10,000. Elective central line CVS catheterization is there, then 20,000. Chest tube insertion and thoracocentesis 50,000. For bronchoscopy with lavage 20,000. Prior to paracentesis, usually not required. Prior to bone marrow biopsy also, it's not required. Prior to elective diagnostic lumbar puncture, minimal at least 50,000 platelet count should be there. If it is urgent, then 20,000. Prior to elective surgery, excluding neurosurgery, 50,000. If it is neurosurgery, then 1 lakh. Traumatic brain injury and intracranial hemorrhage, 1 lakh. And prior to the insertion of IVD, 1 lakh. Now, specific therapy. Certain conditions like HIT and TTP have specific therapy, which when timely initiated, have shown good outcome. Like in heparin-induced thrombocytopenia, the main management of thrombocytopenia and HIT is to stop unfractionated weight heparin or low molecular weight heparin in any form and initiate the patient on alternative form of anticoagulation like direct thrombin inhibitor and antifactor 10H. Then in a case of TTP and HOS, Mortality in patients with TTP had shown to be close to 90% without plasma exchange, which is the mainstay of management. Other therapies like steroid, cyclophosphamide, anti-CD20 agent have also been tried, but with lesser efficacy as monotherapy compared to plasma exchange. Thank you, guys.